So it used to be very difficult to, whenever you have very large angle, I would show some of the videos. When you have very large angles, it becomes extremely difficult to save for the ocular motility. And muscle transplantation, at least whenever we have done it for these large angles, it has come to a very good rescue for us. And I'll be showing some of the videos for esotropia, hypotropia. We have used it in nystagmus patients. We have even used it for one eye muscle for other eye recession. So this is one of the patient. There is a very large angle esotropia. We know a standard single eye surgery recession resection would yield around 50 prisms or something like that. And if you go for a very large recession, it would end up into having significant ocular motility issues. So this was one of the early days when we were doing recession, muscle transplantation. We have dissected the medial rectus as you will do as a standard recession. And then we did the recession with a 6-proline. And this is a standard resection, except that here we are using two set of 6-vicryl. And we are removing the lateral rectus. This particular stump, which would otherwise won't be useful, this particular stump we will be suturing back to the medial rectus, and this is what we are calling as true muscle transplantation. This is a free anastomose. Just for the sake of information, this muscle tissue will not be viable. It will be more like a fibrotic band, like a spacer. So our theory is that the way it works is that it keeps the actual insertion anterior to the arc of contact, and that is how we get a superior ocular motility. And this is a standard recession otherwise, except for the fact that the muscle was transplanted. And we had a couple of publications on this, and these are the results. You can see that it works very well, but then a large recession would have worked equally well. The good part is that you can see a wonderful ocular motility, like it is almost like -half or something like that, but otherwise it is a very good ocular motility of the right eye even after 1 month. This is 1 month post-op, this is immediate post-op. This is another patient and another patient just to show you that this particular patient actually had abduction restriction pre-op, and post-op abduction obviously is good, but even adduction is quite good. I mean, with such a large angle, doing such a large recessions, almost to the tune of 80 prism esotropias, and similar results. This was a patient, this was a thyroid patient actually, and he had a very large hypo, and we thought we will do inferior rectus recession, and then we thought that maybe we can do a muscle transplant. This was pretty large. This was around 75 prisms hypotropia. And to our surprise, post-op movement, normally if you do inferior rectus, all of us have done inferior rectus, we know what happens. Even with a standard 5.5 millimeter recession of inferior rectus, we see huge ocular motility restriction, at least in down gaze. I will show you, this is the primary position. Post-op we had, yeah, I would show you the up gaze, this down. Pretty good ocular motility is there compared to the right eye. We will be going with the right eye only, not with a standard normal patient, but he has pretty good ocular motility compared to what we would see otherwise in a large inferior rectus recession. So this was pretty large. This was like 5 millimeter of inferior rectus recession. On the top of it, another band of superior rectus, which was around 5 millimeter that we did. So the results are very good. This is another patient. Now we have a pretty large series for esotropia, and there's a very good series by Dr. Sandra on exotropia. And there have been a lot of reports from Dr. Ramesh, Dr. Jaspreet, Sableen. Most of us have now done muscle transplantation. It works very well. The important part is that the restriction of ocular motility is not that big. This was what we hypothesized and published in IGO, that the actual insertion remains anterior to the arc of contact, and that maybe gives the good results that we see with muscle transplantation. So we feel that it is simple because it is very similar to what we would be otherwise doing for esotropia or exotropia. Some underaction in primary position of the muscle is definitely seen, but it can be combined with other procedures. We operated a patient who was already operated for strabismus and had a face turn for actual nystagmus, and we took lateral rectus of one eye and put it on the medial rectus of other eye. So we feel that it is a safe and alternate option for very large angle strabismus, especially when we want to do a uniocular surgery. And the surgical results are stable. We have followed these patients for very long, and they are quite stable. So we would recommend this particular surgery if we have to do a uniocular surgery. So thank you so much, and I would